Guys, my topic is small incision cataract surgery. That's some way a quicker way of doing it. It's more of a video presentation. I have just 2 slides of the documents from this presentation. As we know, small incision cataract surgery is simple. Simple means it's easy to do and perform. It's safe that no dreaded complications are there. It's easy to learn and perform. Quickly it can be done. And it's flexible. There are many modifications and different people have devised different modality of doing it. So there's a lot of flexibility unlike SICS, where we have a definite frame of the presentation or the doing or the technique that you can't move out of those 4 or 5 techniques of shutters of doing the field emulsification. It's cheap, of course, no much investment is required, even in our peripheral hospitals where the FICO facilities are not available. Anybody can perform it, and it has good visual outcome. That's why this procedure of doing cataract surgery will remain relevant for quite some time until the FICO replaces it all across the country and the world. I am just presenting one of the easier way of doing it. There are many ways. I do not advocate it to be the best, but it's an easier way of doing small incision cataract surgery. This is how this cataract surgery started. The way you do FICO emulsification. Just in the posterior part of the limbus, you push the knife, the keratome, and almost 3.2 by 3.2 step incision is made. Instead of making a classical conventional tunnel, particularly in these hard cases, exfoliation cases, this was the case of mature cataract with dense exfoliation. You can see pupil is not fully dilated, and there was some donesis also during the surgical examination. So once you make this stab incision, conventionally we go the way we do for FICO emulsification. I go for almost a similar siting of incision whenever FICO emulsification is done. In harder cases and a bit risky cases, or where the endothelial is likely to be compromised, in harder cases require higher energy, and invariably they have post-operative edema. And in small incision surgery, the damage is not that much. Particularly, it is done without much manipulation. This is something I tend to do in these cases, particularly when small incision is done. The small nick in the rexis will just relax if in case the corticonuclear mass, it doesn't get trapped up into the this is what I advocate. That is, you need to engage it, because sometimes conjunctiva comes on your way, and just extend straight away this tunnel about 3.2 or 3.5 millimeter into 5.5, so that 1 millimeter or half millimeter on either side, particularly the internal extension is required, so that this comes out easily. So the ratio of this length to breadth, what is the standard teaching, is almost 50% of the length to breadth ratio, and almost it is absolutely a sealed tunnel. It hardly has, I never had leakage out of my cases that I have been doing for the last 10 years with this technique. This is how it is hydrodissection, delineation, and delivery simultaneously. So you can see hardly the time is just 2.5 minutes, and the cataract is almost over that. This lens has come out, and sometimes just assistance is required. In case the corticonuclear mass is disproportionate, then the visco delivery or the vectis delivery or hydro delivery, anything could be done. You can visco express the cortical matter out, although the pupil has gone down, as happens usually in these cases. And particularly pseudo exfoliation, that as soon as the pupil is touched by the delivering nucleus, the pupil goes down. But still, you can see most of the cortex and nucleus is out. Some part of cortical matter that can be cleaned directly. The hemorrhage, which most of my colleagues say that bleeding might be an issue, usually no blood goes inside even after the direct extension. You can see most of the blood comes as the tunnel is broad enough to seal it, that the free flowing blood just comes out, or otherwise you can push some viscoelastic just to ensure that blood doesn't interfere, and usually it doesn't interfere. So this cortical cleaning up is done, and some, as the pupil has gone down slightly, some part of lens matter, if at all is there, you can push the angle into the back, and once you dilate the part of lens matter, particularly in the upper sub-incisional area, can be taken out. IUL can be implanted in these cases, although capsular rims are not visible, but you ensure that a slightly deeper placement of the figure haptic will just ensure this, since this is the IUL of a premium brand, so it will easily go and comfortably you can push it inside the bag, and that will almost complete. You can see the part of lens matter has come out once you push the IUL into the bag, and that can be cleaned, and the almost your lens placement is there. Just push, remove this lens matter out of whatever residual lens matter is there. Just tap the interior surface of lens, as you know that this will just remove whatever field lens matter is there, and some I will just push the optic which